So the next topic for today is From Replacement to Regeneration, Orthobiologics Change the Geriatric Orthopedic Care. And our esteemed speaker for the day is Dr. Vishnu Baburaj, Consultant Orthopedician, KIMS Hospital, Kasaragod. We welcome you, sir. And the chairpersons will be Dr. Sunil V., Professor and Head of the Department of Orthopaedics, Government Medical College, Kannur, and Dr. Avinash Kakunje, Senior Consultant Physician, Astromems, Kasaragod. May I invite the chairpersons to come forward to take their seats.
So, over to Dr. Vishnu Ba. I think he was already introduced by...
I'll just tell about this. Good morning to you all. Dr. Vishnu Baburaj is a colleague of my own. He was working at KIMS Kasaragod Hospital as a consultant orthopedician. He did his MBBS from Madras Medical College, went on to do MS Ortho from PJ Chandigarh and DNB from there. He has completed extensive post-graduation training from PJ Chandigarh, one of the India's premier institutes. He has spent 6 years of specialty in complex trauma, arthroplasty, and arthroscopy from the same institute. He's an accomplished researcher with over 30 publications in international papers, journals, and he has been working at KIMS Kasaragod since last 6 months.
Yes, sir.
Yeah. Over to you, Vishnu Baburaj, sir. I think it's an important topic. A lot of patients, geriatric, especially 60-plus patients, I think one of the most common problem is fall and problems associated with it. Over to you, sir.
Say one more thing. Let me add one more thing. One is, there are two things. One is replacement and regeneration. Okay? And that is what is the topic of today. What I would like to add is, these patients, especially old age patients, they are more subjected to trauma around the hip as well as the spine. In fact, 90% of the spine pelvic fractures that come into casualty is of this group. And early intervention, that is the most important thing that is required for this patient. Or else, as we have studied before, that is life begins through the brim of the pelvis and life falls out through the brim of the pelvis. In fact, geriatric orthopedics has definitely changed the fate. In fact, after early intervention, most of the patients whom we would have lost previously is doing well. Thank you. Let's continue.
So, thank you for the kind words, sirs. So, good morning, everyone. I thank the GSI organizing team and Dr. Prasad Menon for this opportunity. So, my goal today is to talk about a shift that is happening in the field of orthopedics. So, this shift, I believe, will have a profound impact on how we manage our geriatric patients. So, traditionally, when joints wore out or when bones failed to heal, our answer was usually a mechanical one. Hip replacement, knee replacement, mechanical prostheses, screws, plates. But what if instead of replacing what was lost, we could actually help the body regenerate it? So that is the promise of orthobiologics. So in this session, we'll see how these emerging therapies are shifting the paradigm in orthopedic care, especially in the geriatric population. This is not moving. Yeah. So let's start with the problem. I'm sure most of us see this on a day-to-day basis. So with increasing life expectancy, we are starting to see a lot more of osteoarthritis, osteoporosis, and fragility fractures. So traditionally, we used to consider a mechanical solution to all this. That is in the form of a hip replacement and a knee replacement. So, but the issue is that the geriatric population are not always a good candidates for these surgical procedures. They have medical comorbidities, longer recovery, and are prone to complications. And also, these procedures are expensive, and cost is a limiting factor. So, what is the solution? So, the limitation of our traditional toolkits, we often go to these traditional toolkits such as NSAIDs, oral steroids, physiotherapy, and sometimes local steroid injections. But the fundamental problem with these treatments is that although they are excellent at managing symptoms, they don't basically alter the course of the degenerative disease. And also, while dealing with geriatric patients, we face a unique challenge because they have medical comorbidities, and this patient population is more vulnerable to the side effects of these drugs. So this dilemma is actually forcing a paradigm shift in our thinking. Historically, the story of arthritis used to be a story of waiting until the joint wore out and then offering a mechanical solution. That is a joint replacement. But the promise of regenerative medicine is to intervene early and preserve the biology. So it makes use of the body's incredible capacity to heal itself rather than offering just a mechanical solution. So how do we do this? We use a set of tools collectively called orthobiologics. Orthobiologics are biologic agents that can either be derived from the patient's own body or synthesized with specialized techniques that promote healing. They are minimally invasive and cost-effective alternatives. So we'll see the main tools that we'll explore today. They are platelet-rich plasma, PRP, bone marrow aspirate concentrate, BMAC, mesenchymal stem cells, tissue engineering and scaffolds, and some newer modalities such as nanofat, stromal vascular fraction, and exosome therapy. So let's start with PRP, the most familiar one. I'm sure most of us would have at least heard of PRP. The concept is very simple. We take a small sample of the patient's own blood and spin it in a centrifuge to concentrate the platelets. Platelets, as you all know, contain a lot of growth factors and other things that regulate inflammation and stimulate healing. So these concentrated platelets can then be injected precisely where it's needed. So the two main indications of PRP are in knee arthritis and in chronic tendinopathies that don't seem to respond to anything else, such as tennis elbow, also known as lateral epicondylitis, Achilles tendinitis, and lesser so for rotator cuff tendinopathy. It has shown good evidence in mild to moderate osteoarthritis, reducing pain and improving function. So evidence of PRP, studies have consistently shown PRP to outperform placebo or even hyaluronic acid in osteoarthritis of the knee. It is safe and low cost, but some caveats are that the preparation method is highly variable. Depending upon the kit and the center you get, the concentration of the platelets in the PRP is highly variable, and we also lack long-term data. The available studies are mostly early to mid-term studies. But even though for our elderly patients, even a year or two saved without surgery can be a big thing. So coming on to the next thing, platelet-rich fibrin, PRF, that can be considered as an evolution of PRP. So basically the only difference between PRP and PRF is that in the preparation of PRF, we don't use anticoagulants. This means that while centrifugation, the blood naturally clots. This forms a fibrin-rich matrix which traps the platelets and slowly releases the growth factors. So the key difference between PRP and PRF is that you can consider PRP as a quick burst of growth factors, whereas a PRF is a slow, sustained release of growth factors. So this can be especially useful in elderly population because already their tissue healing is a bit slow. So PRF has unique advantages in this specific age group. The applications are similar to PRP in bone regeneration, osteoarthritis, and tendinopathies. So coming to bone marrow aspirate concentrate, here we take a bone marrow aspirate mostly from the iliac crest and concentrate it. The concentrate contains stem cells and growth factors. So they can be injected into joints, cartilage defects, and bone non-unions. Especially in tibia non-unions, the BMAC injections have shown to stimulate healing and promote union. So if you're able to tell your patient that rather than having a second surgery, a simple needle procedure can help your fracture heal to an elderly patient, that would be really advantageous. So evidence has been good, but not perfect. It obviously does well in bone non-unions, early osteoarthritis, and cartilage repair. But the main problem is that most of the evidence comes from small studies. The harvesting technique or iliac crest harvest can be painful if done without anesthesia, although it's particularly safe. And the harvest also contains only a small percent of stem cells. Only about 0.01% of the harvest contains the actual stem cells. So these are some of the limitations of BMAC. So next up is mesenchymal stem cell therapy, MSC. They have attracted a lot of attention recently. MSCs are multipotent adult stem cells that are capable of differentiation into cartilage, bone, or tendon tissues. So they are mostly experimental at this stage and not widely available for clinical use. But the main, looking into the future, what researchers are trying to do is basically, if we're able to inject the mesenchymal stem cells into a knee of a patient with osteoarthritis, and if you're able to regenerate cartilage, that is the future outlook for MSCs. But as of now, they are mostly experimental outside of clinical trials, and regulatory, ethical, and cost issues still constrain the use. So how do we decide between PRP and stem cells, that is bone marrow or mesenchymal stem cells? So the fundamental point of decision boils down to the severity of the underlying condition. PRP is best suited for mild conditions, whereas cell therapy is reserved for more advanced or more severe conditions, where a more powerful signal is needed to regenerate the tissues. So coming to tissue engineering and scaffolds, this is where biology meets material sciences. So basically scaffolds can be either natural or synthetic. They are basically a framework sort of thing that allows cells to bind onto them, grow, and regenerate into healthy tissues. So it is currently used extensively in bone defects to fill large bone gaps. They're also being studied in cartilage defects. So coming to nanofat, SVF, and exosome therapy. So other than the familiar PRP and stem cells, newer frontiers have emerged. Nanofat and stromal vascular fraction, SVF, they are derived from adipose tissue, fat tissue. They are rich in regenerative stromal cells. These are mainly employed in plastic and cosmetic surgeries for facial rejuvenation, wound healing, wound contraction. But they can also be used in orthopaedics in osteoarthritis, tendon repair, and cartilage regeneration. Similarly, exosomes are tiny extracellular vesicles. Basically, they are signaling molecules, signals for the growth factors. So if you're basically able to isolate the signals without the cells, that can avoid all the drawback of cellular therapy while making use of just the signals. That is the promise of exosome therapy. So what does this mean for our geriatric patients? Firstly, they are minimally invasive. Most of them are a small, simple needle procedure or an injection rather than a major surgery. So they have lesser risk and better recovery. Secondly, they can act as a bridge therapy that can either delay a major joint replacement or avoid a joint replacement altogether. And thirdly, they can improve the quality of life, allowing patients to walk or climb stairs without debilitating pain. So this is probably one of the most important slides. So while orthobiologics are powerful treatments, they're not like magic bullets. Patient selection is everything. So who is not a candidate if your arthritis is already very advanced, what we call bone-on-bone disease, where the bone is touching each other, the cartilage is completely damaged. So regeneration needs a scaffold to build upon. If the joint space is already completely damaged, then that by default is a mechanical problem that requires a mechanical solution in the form of a joint replacement. In such advanced arthritis, these biologic treatments will not offer much benefit. So, coming to limitations, the evidence is mostly short to mid-term that I already discussed, and we need standardization methods because multiple kits available in different centers make different types of PRP with different concentration of platelets. Same as for BMAC. And cost versus benefit analysis is required because although these treatments are affordable relative to surgical treatments, if we consider multiple injections, the costs will add up. And the future is obviously in combining biologics with scaffolds to offer a comprehensive regeneration. So to conclude, the promise of orthobiologics is a shift from a reactive to a proactive preservation. So rather than wait for a joint to wear down and then offer a joint replacement, we are proactively allowing these biological molecules to replenish and regenerate the tissues. So the future of geriatric orthopedics isn't just about getting better at doing joint replacements, but it's about making joint replacements less necessary in the first place. So for our geriatric patients who may not be good candidates for a major surgery, orthobiologics offer new hope. And this hope is not just theoretical, it's here and it's available at KIMS Hospital, Kasaragod. Every therapy that we have discussed is part of our treatment armamentarium, from PRP to exosome therapy and tissue engineering. So I encourage you all to make use of these therapies for your patients, to guide them and let them know that they need not spend their time in pain and waiting for a knee replacement or a hip replacement surgery. Thank you very much.
Okay, thank you, Dr. Vishnu. Since we are short of time, I think we'll wind up the session.